Welcome to the Radonc Smart Review Head and Neck Cancer Series.
Today, we are undertaking a critical and pretty extensive exploration into the technical core of definitive radiation planning.
That's right. And our focus for this session is a definitive planning workshop. We're going to cover simulation, target volumes, and organ at-risk constraints, specifically for oropharyngeal cancer, or OPC.
And this is, it's more than just reviewing facts. This is really about building a clinical defense for your decisions.
Exactly. If you're preparing for your written or oral boards, the level of detail we're getting into here is exceptionally high yield. Examiners don't just ask for the numbers.
No, they don't. They test your systematic thinking.
Right. How exactly do you delineate your targets? What's the algorithm guiding your nodal coverage? And I think most critically, how do you defend the trade-offs when a plan needs optimization?
Our goal here is to equip you with a really robust, board-defensible framework for definitive OPC planning. We're going to use a step-by-step approach, and we'll anchor all of our technical decisions to a single illustrative clinical case.
So we're translating those high-level guidelines directly into, actionable contouring and dose planning strategies.
Precisely.
Okay, let's anchor our discussion immediately with our case patient, since every decision we make today is going to flow from their specific anatomy and staging.
Our patient is a 62-year-old man. He's presenting with P16 positive squamous cell carcinoma of the right tonsil. And this is staged T2N1M0, according to the AJCC 8th edition.
And we should probably highlight the key anatomical details because they're really what dictates the complexity of the plan here.
Absolutely.
The primary disease, it extends onto the soft palate, and that's a crucial point for laterality and nodal risk down the line.
It is. And the involved nodes include a pretty substantial 4-centimeter right level 2 node and also a 1.5-centimeter right level 3 node.
And thankfully, the PET-CT confirmed no distant metastatic disease.
Right. So based on that presentation, the treatment decision, as we determined before, is definitive IMRT with concurrent cisplatin. We're now tasked with executing that plan with maximum precision.
So before we dive into the nitty-gritty, let's just lay out our roadmap. Over the next 40 minutes or so, we need to answer 6 core planning questions for this patient. So first up, what is the optimal simulation setup method?
Second, how do we systematically define and delineate our 3 target volumes?
Third, and this decision is often the make-or-break moment on oral boards. Based on that soft palate extension, do we treat the bilateral neck or just the ipsilateral neck only?
A huge question. Fourth, once we decide on that laterality, which specific nodal levels must we cover electively and which ones can we safely spare?
Fifth, what are the crucial OAR constraints? We're talking the mean dose limits for structures like the parotid glands, the pharyngeal constrictors, and what clinical toxicity are we actually preventing with each of those numbers?
And finally, what dose and fractionation scheme are we going to use and how do we prioritize coverage goals versus OAR constraints when they, inevitably conflict?
That's a comprehensive agenda. Let's start at the very beginning, the foundation of treatment, by discussing treatment techniques, specifically simulation setup and positioning.
Yeah, let's do it.
We've all heard it, but it really bears repeating. If the simulation setup is suboptimal, even the most elegant dose distribution is clinically worthless.
That is absolutely correct. Immobilization isn't just a regulatory checkbox, it's really our primary defense against geometric uncertainty.
So standard positioning is, of course, supine, and we're using a high-quality thermoplastic head and neck mask. But let's talk about the nuances of positioning that are so critical in OPC.
Okay, so the first critical detail is achieving a comfortable extension of the neck, so a slight chin-up position.
And the intent there is what exactly?
The intent here is purely anatomical. By extending the neck, we move the uninvolved parts of the oral cavity and the anterior neck skin out of the primary beam path.
Which can significantly reduce the volume of uninvolved mucosa getting a high dose.
Exactly. And that helps mitigate acute mucositis.
Okay, and the second detail, which is often overlooked but so essential when you're treating T2N1 disease that probably involves the low neck, is ensuring the shoulders are pulled down and secured. Why is that shoulder position so crucial for coverage?
It relates directly to the physics of IMRT or VMAT. If the shoulders aren't adequately immobilized and depressed, they introduce a large volume of dense tissue right into the exit path of the beam.
Especially when you're trying to treat those low-level 4 nodes with the supraclavicular fossa.
That's right. And this results in two major problems. First, it causes dose heterogeneity and attenuation in that low neck region, potentially compromising CTV coverage.
And the second?
And second, it increases the total volume of tissue irradiated, which drives up the monitor units needed, and that elevates the total integral dose. Pulling the shoulders down just removes that physical obstacle.
That's a great physics rationale. Now, let's tackle the famous board question, the bite block decision. When, and maybe more importantly, why, do we use an intraoral device for a tonsil primary?
Well, the general rationale for a bite block is twofold. First, improved setup reproducibility, it gives you a firm reference point, and second, anatomical displacement.
Right, for subsites like base of tongue or nasopharynx, it seems like it's high value because it pushes the tongue and palate away from that high dose volume.
It does. It offers substantial sparing in those cases.
But our patient has a tonsil primary. Does that same high value rationale apply here?
This is a point of nuance, and you'll see institutional variation. Since the tonsil resides in the tonsillar fossa, which is a structure surrounded by the pharyngeal wall, a bite block might not dramatically change the spatial relationship of the tongue relative to the primary target volume.
So some places might just skip it entirely for tonsil cancer.
Yes, some centers omit it entirely.
So if we choose to use one, what's the best defense?
You defend it based on reproducibility. You would state that the device maintains the vertical dimension and prevents involuntary tongue movement during treatment, which lets you reduce the PTV margins needed for setup error.
And if you omit it?
If you omit it, you defend that by stating that for a lateralized OPC primary, the potential sparing of the oral cavity mucosa is minimal compared to the increased difficulty of contouring and, patient comfort.
That balances the argument perfectly. Okay, moving to the imaging protocol, which directly informs our contouring. What's the bare minimum CT simulation requirement?
We must have a CT simulation with 2 millimeter slice thickness. I wouldn't call this a recommendation. It's really a requirement for high-quality head and neck planning.
And why is that?
Thinner slices are just essential for distinguishing small nodal margins, especially in that level 2 region, and for accurately visualizing fine structures like the pharyngeal constrictors and the cochlea.
And what about contrast?
Intravenous contrast is not optional. It is essential for nodal delineation. We need to clearly visualize the relationship between the involved nodes, like our 4 centimeter level 2 node, and the surrounding vascular structure. This is critical for contouring and for recognizing potential extracapsular spread.
For OPC, though, CT alone is often insufficient for mapping the true extent of the primary tumor. And this is where MRI fusion comes in.
Exactly. MRI fusion is strongly recommended. Specifically, you want to include T1 with contrast and T2 sequences.
Because the CT scan tends to underestimate the disease extent.
Right. It consistently underestimates the mucosal and submucosal extent of the disease, which is exactly why our patient's soft palate extension might be more extensive than a CT suggests. The T2 sequence is particularly important for defining tumor margins and identifying surrounding edema.
What's the risk, clinically, if we neglect the MRI fusion?
The risk is a gross underestimation of the GTV. We might draw the line too tightly, which could lead to a geographic miss around the primary, especially where the tumor interfaces with muscular structures or mucosal planes.
And given the TROG 0202 data, which we'll get into soon, compromising the GTV is probably the deadliest error we can make.
It is.
So let's define the scan extent. How far up and down do we go?
From above the head, including the whole brain down to the carina. This ensures we cover all potential drainage pathways, including the supraclavicular fossa and the entire upper mediastinum.
And finally, isocenter placement. For our bilateral neck plan, where should that be?
If we are planning a bilateral neck treatment, placing the isocenter anterior to C2 is standard practice. This central superior position allows for the most symmetric beam arrangements, optimizing IMRT or VMAT delivery.
Got it. Okay, so we've established a really rigorous simulation setup. Now let's integrate all those steps into a single, concise planning summary, basically a script you should have memorized for any oral examination.
I will deliver the planning summary exactly as presented, integrating the clinical details of our 62-year-old patient.
Okay, let's hear it.
For this HPV-associated T2 tonsil cancer with ipsilateral level 2 and 3 nodes and soft palate extension, I'd simulate supine in a thermoplastic mask with comfortable extension and shoulder, CT with IV contrast, and MRI fusion for mucosal. GTV includes the primary and involved node. I contour a high-risk CTV as GTV, plus about 5 millimeters anatomically cropped, with a 3 to 5 millimeter PTV depending on daily CTV. Elective CTV covers at-risk nodal levels, typically ipsilateral levels 2 through 4, with appropriate upper neck coverage to skull base. Retropharyngeal coverage is added when anatomy indicates, especially posterior pharyngeal wall involvement. For neck laterality, ipsilateral only is reserved for a well-lateralized tonsil primary that stays greater than 1 centimeter from midline with 1 centimeter or less of mucosal base of tongue or soft palate involvement and minimal nodal. If extension is borderline or clearly greater than 1 centimeter, I treat bilaterally at minimum, contralateral high level 2. Dose is 70 gray to gross disease with an IMRT-SIB to elect. I prioritize cord and brainstem limits, maintain CTV coverage, and optimize xerostomia and swallowing outcomes with parotid mean dose goals around 26 gray when feasible, and dysphagia-sparing objectives for pharyngeal constrictors balancing trade-offs.
That is a dense but incredibly high-yield summary. Before we move on, I want to zero in on a point you made about prioritizing CTV coverage.
Okay.
That brings us to our next major section, target volume delineation, where we really have to confront the true consequence of poor planning.
Yes, we need to spend some serious time discussing the TROG 0202 trial. It is the defining historical reference for why meticulous contouring is so paramount.
A lot of residents know the headline numbers, but let's put this into context. TROG 0202 looked at patients with advanced head and neck cancer who were getting accelerated fractionation with concurrent cisplatin. When the investigators reviewed the submitted treatment plans, what did they find about the quality?
They found that a staggering 25% of the submitted plans had major protocol deviations or deficiencies, and these deficiencies were often related to geographical misses or just underdosing of the target volumes.
And what was the clinical fallout of those errors?
The consequences were devastating. For patients who had major planning deficiencies, the 2-year overall survival dropped from 70% all the way down to 50%.
Wow.
And that 20% survival hit, purely from a planning error, was found to be statistically greater than the survival benefit provided by the concurrent chemotherapy itself.
Let that sink in for a moment. You can give the right chemo, the right dose, the right fractionation, but if your contours are wrong, you can literally negate the entire survival benefit.
It proves that contouring is a therapeutic intervention in and of itself.
It absolutely does, which forces us to define our targets with absolute rigor. So let's start with the GTV definition, the gross tumor volume.
Okay. GTV primary. This is all visible and palpable tumor. It's synthesized information from your clinical exam, the CT scan, the PET-CT, and, crucially, the MRI.
Right. We can't stress enough that the MRI is the gold standard for defining that mucosal and soft tissue disease extent in the oropharynx.
And for GTV nodal, we include all radiographically involved lymph nodes. The size criteria generally follow a short axis greater than 1 centimeter. However, we have to nuance that rule based on location.
For example?
Well, retropharyngeal nodes are often smaller, so a 6 to 8 millimeter node there might be included. Conversely, a large level 2 node might be slightly greater than 1 centimeter, but you might deem it reactive if the internal architecture is completely normal and it's PET negative.
But generally, if there's central necrosis or it's PET avid, or you see visible extranodal extension.
Then they go into the GTV nodal, regardless of that strict 1 centimeter cutoff.
And if we spot visible extranodal extension, or E&E, outside the nodal capsule on an MRI,
that visible E&E must be included within the GTV nodal volume itself. You are treating gross disease that has already broken the nodal barrier.
Okay, now we address the microscopic disease with the CTV definition. Let's focus on the mnemonic that helps systematize this whole approach, the 5+5 rule.
Right. The 5+5 rule describes the geometric expansion margins for the 3 tiers of CTV that we use in a simultaneous integrated boost, or SIB, plan.
Let's start with CTV high, the 70 gray target.
This is defined as the GTV plus a 5 millimeter isotropic expansion. This margin covers the immediate high-probability microscopic disease extension right around the gross tumor.
And the crucial caveat here is anatomically cropped. We don't just expand 5 millimeters into the pterygoid plates or the air of the nasopharynx.
Precisely. You have to sculpt that 5 millimeter margin along natural anatomical boundaries at bone, at air cavities, and at structures like the intact prevertebral fascia, which act as barriers to local spread.
All right, what about CTV intermediate, the 60 to 63 gray target?
This is where we cover the GTV plus a 10 mm margin and the anatomic areas that are at high risk due to their proximity to the tumor and their known lymphatic drain.
So this would include the first echelon nodal stations and the immediate pterolymphatic regions. I know some centers skip this intermediate tier. They go straight from 70 gray down to 56 gray. Is that approach defensible?
It is acceptable according to ASTRO guidelines, which do allow for a 2-tier SIB. The rationale for the 3-tiered approach, which we recommend in the academic setting, is that it manages the dose gradient more smoothly.
So it could potentially spare OARs that are right at that interface between the high and low dose volumes.
Right, like the pharyngeal constrictors.
Okay, and CTV low, the 54 to 56 gray target.
This volume covers the second echelon nodal levels and the remainder of the elective coverage regions, basically the uninvolved neck at risk.
Let's talk about the evidence for tight margins. For years, we used 1 centimeter or even wider margins. Now we're comfortable with 5 millimeters. What data supports this shift toward precision?
We rely heavily on the long-term data from the Da Han Ka experience, which was published in 2024. That group standardized their practice to a 5 millimeter GTV to CTV high margin starting way back in 2013.
And what did their detailed analysis show regarding local control?
It showed that transitioning to these standardized, very precise 5 millimeter margins did not compromise the 3-year local control rates. They remained robust at about 87%.
And when local recurrence did happen,
it was overwhelmingly found within the high-dose volume.
So the key takeaway is that if you trust your imaging, meaning you have high-quality MRI and rigorous systematic contouring, the extra volume of the larger margin just causes unnecessary toxicity without improving tumor control.
Precision is the ultimate goal.
Right. Now, let's get specific about the anatomic considerations for OPC, specifically a tonsil primary, like our patient has. When we draw that CTV intermediate, what structures must be included?
For a tonsil primary, the immediate high-risk zones that have to be in the 60 to 63 gray volume are the ipsilateral soft palate, extending up to the midline, the anterior and inferior aspects of the glossotonsillar sulcus, the retromolar trigone, and the adjacent ipsilateral base of tongue muscle.
And we also have to include the ipsilateral parapharyngeal space.
We must. That space acts like a highway for lymphatic and perineural spread from the tonsil region. If you miss coverage there, you risk a lateral relapse deep to the pharyngeal wall.
Speaking of barriers, let's quickly review our anatomic barriers. When do we stop that 5 millimeter or 10 millimeter expansion?
We stop when we hit structures that disease rarely, if ever, crosses unless they're grossly involved. This includes intact cortical bone, the prevertebral fascia, which is the effective posterior boundary of the pharyngeal wall, and obviously, air cap.
And the critical note for the resident is this. If the MRI shows that barrier has been transgressed, like, for example, involvement of the prevertebral fascia, then the whole compartment beyond that barrier is now at risk.
And must be included in the high-dose CTV.
Finally, let's define the PTV margin, the planning target volume.
This is what accounts for our geometric uncertainties. The standard range is CTV plus 3 to 5 millimeters.
And that depends on your image guidance.
It does. The 3 millimeter margin is acceptable only if your institution uses daily image guidance, like cone beam CT, which corrects for patient setup variation and minor motion. If you can't use daily CBCT, you must use a 5 millimeter margin to account for that increased setup uncertainty.
So for our patient, we'll assume modern CBCT usage and proceed with 3 millimeters.
Correct.
To consolidate this, let's apply the full target volume summary back to our case patient.
Okay. Our T2N1 right tonsil case requires GTV primary, which is the tonsil and soft palate extension, then GTV nodal for the 4 centimeter level 2 and 1.5 centimeter level 3 nodes.
Then the CTVs.
CTV 70 is the GTV plus 5 millimeters, cropped at bone and air. CTV 63 is GTV plus 10 millimeters, covering those high-risk areas like the ipsilateral parapharyngeal space, the sulcus, and the base of tongue.
And the low-dose CTV.
CTV 56 covers the rest of the elective neck nodes we'll define next. And finally, PTV is the CTV plus 3 millimeters with daily image guidance.
That systematic approach is exactly what an examiner wants to hear. And it leads us directly into our third major decision: bilateral versus ipsilateral neck coverage.
And this is arguably the most common and controversial clinical decision in OPC planning.
It forces us to make a direct trade-off, doesn't it? Risking a geographic miss versus accepting unnecessary, irreversible late toxicity like xerostomia.
Exactly. We have to defend this decision based on established data.
So we use the decision framework established by the American Radium Society, or ARS, appropriate use criteria. Let's delineate the specific criteria that must all be met to justify treating ipsilaterally only.
Okay. First, the tumor must be well lateralized, either tonsil confined or remaining greater than 1 centimeter from the midline. Second, mucosal involvement of adjacent structures like the base of tongue or soft palate must be minimal. We define that as less than or equal to 1 centimeter.
And third, the nodal burden must be minimal, 0 to 2 involved nodes. Our case patient has 2, so he's right on that threshold.
And fourth, there must be no posterior pharyngeal wall involvement. If all 4 of those criteria are met, retrospective data confirms the risk of contralateral neck failure is low, typically less than 3%.
So in that case, ipsilateral treatment is safe and necessary to preserve quality of life.
Oh, correct.
But the nuance often trips up residents, particularly this greater than 1 centimeter problem. How do we practically measure mucosal extension?
This is where we have to acknowledge the limitations of imaging. Even with a high-resolution MRI, determining if a tumor extends 0.9 centimeters or 1.1 centimeters past some arbitrary boundary, it can be highly subjective and suffer from inter-observer variability.
It's not like measuring a bone lesion.
Not at all.
So if the imaging is borderline, or if the clinical exam was difficult because of pain or trismus, what's the board-safe approach?
You err toward bilateral treatment. We rely on the principle that the consequence of undertreatment, a relapse in the contralateral neck, is clinically far more severe than the consequence of overtreatment, which is increased xerostomia.
Which, while serious, is manageable.
Right. So when in doubt about laterality, you favor safety over sparing, especially when you're giving concurrent systemic therapy.
Let's talk about the no consensus situations that ARS defines. Where does the data stop giving us a clear answer?
This is typically when we see more than 2 ipsilateral nodes, definite clinical extranodal extension, or really bulky disease, say greater than 6 centimeters.
So in those scenarios, the risk of unusual spread is higher.
It is. And the treating physician often opts for bilateral coverage as a prophylactic measure, even if the midline criteria are technically met.
Now, what are the clear bilateral indications where ipsilateral treatment is just indefensible?
Any primary originating from a midline structure, so base of tongue, posterior pharyngeal wall, or a soft palate primary itself. Any tumor that's approaching or crossing the midline.
Or a tonsil primary with extension that's clearly more than 1 centimeter onto the soft palate or base of tongue.
That's right. And as we mentioned, ipsilateral retropharyngeal node involvement often necessitates bilateral coverage due to the unique drainage pathway.
Let's apply this risk ladder directly to our case patient. T2N1, right tonsil, with soft palate extension and 2 involved nodes.
Our patient is borderline. He has 2 nodes, which meets the maximal limit for minimal nodal burden, and he has soft palate extension, which is the major risk factor.
So it all comes down to that measurement.
It does. If we assume the soft palate extension is greater than 1 centimeter, he becomes a clear bilateral candidate. If it's less than 1 centimeter, he's an ipsilateral candidate.
So the board defensible recommendation in this scenario where the risk is elevated would be?
We would recommend bilateral neck treatment. Because he has nodal disease and soft palate extension, opting for bilateral coverage at a minimum, including the contralateral high level 2, 3, and 4, it just provides that necessary geographic margin of safety.
We minimize the contralateral dose, but we don't omit the elective coverage.
Exactly. And even with that decision, we can still practice contralateral de-intensification. We don't just blast the entire contralateral neck to the full elective dose.
So which contralateral levels can we usually omit?
The low-risk levels that are far from the midline are not typically primary drainage sites for OPC. This includes contralateral level 1B, contralateral level 5, and often the contralateral low level 4, especially if the contralateral neck is completely node negative.
So we focus our contralateral coverage on level 2 and level 3.
Yes, because those are the most frequent first echelon drainage sites.
That sets the stage perfectly for our nodal map callout, detailing exactly which levels must be included in our elective CTD.
Okay. For standard OPC coverage, certain levels are non-negotiable because they are the immediate first echelon drainage points. These are levels 2, 3, and 4.
Let's focus on the exceptions and the classic board traps, starting with level 1B. Why is that a trap?
Because level 1B is routinely covered for oral cavity cancers, but the tonsil is pharyngeal. Level 1B drains the oral cavity floor, the lips, the anterior oral tongue, not the tonsil primary.
So routine inclusion for tonsil cancer is just an error.
It is, and the consequence of that error is an increased dose to the submandibular gland.
Which lives in level 1B.
Exactly. If you include this elective volume unnecessarily, you are guaranteeing unnecessary toxicity. So, increased xerostomia without any demonstrable improvement in regional control.
So the specific indication for including level 1B in a tonsil primary plan is what?
Documented extension of the tumor into the oral cavity proper. For instance, involvement of the anterior tonsillar pillar, the buccal mucosa, or the retromolar trigone. If the tumor crosses into the territory drained by level 1B, then and only then do we cover it.
All right, next up, the retropharyngeal nodes, or RP. What makes these nodes so complex to contour?
Well, they're deep, they're located near the prevertebral fascia, and they're a primary drainage site for midline structures in the nasopharynx. We would cover bilateral RP nodes for any nasopharynx or posterior pharyngeal wall involvement.
For our tonsil case, we're more concerned about unilateral risk, given that soft palate extension. When would we cover them ipsilaterally?
We would cover the ipsilateral RP nodes if the primary tumor extends near or onto the posterior pharyngeal wall, or if there's specific nodal disease visible on imaging.
And there's a key anatomical pearl here regarding dysphagia. How can we cover the RP nodes without excessively irradiating the swallowing mechanism?
This refers to the technique developed by the University of Michigan group, often cited as the Feng technique. The key is understanding that for OPC, the medial retropharyngeal nodes, the ones closest to the spine, are usually not at risk.
So by focusing coverage primarily on the lateral retropharyngeal nodes,
we can successfully spare the adjacent superior pharyngeal constrictor muscle. This is a crucial strategy for reducing late dysphagia, as that superior constrictor is highly dose sensitive.
let's finalize the nodal coverage for our case patient, the T2N1 right tonsil with soft palate extension, where we decided on bilateral treatment.
Okay. On the ipsilateral right neck, levels 2, 3, and 4 are mandatory due to the established involvement and first echelon risk. We'd exclude level 1B because there's no oral cavity extension.
And level 5.
We would include level 5 only because there's very bulky nodal disease, which that 4-centimeter node qualifies as. And we'd include the retropharyngeals, but strictly limit coverage to the lateral RP nodes to spare those constrictions.
Okay. And on the contralateral left neck.
Due to the soft palate extension, we have to include the contralateral high level 2 and typically level 3 given the bilateral risk. We often de-intensify or omit level 4 here, but for safety, we'd include at least the upper portion.
And what do we definitively exclude on the contralateral side?
We definitively exclude contralateral level 1B and level 5, as the contralateral risk there is low. We'd also exclude the contralateral retropharyngeal.
That systematic justification provides a really clear rationale for every boundary we draw on that planning sheet.
It does.
Now we can transition into the toxicity prevention framework, OAR constraints. Knowing the absolute limits is just the starting point. We need to know the why, what complication are we actively preventing?
Let's begin with xerostomia prevention. This is really the quality of life outcome that IMRT fundamentally improved.
Right, the PRS-PRT trial demonstrated the impact. IMRT cut the risk of grade 2 or higher xerostomia roughly in half compared to 3D conformal. That's a monumental shift.
It is. Our key constraint is the contralateral parotid gland mean dose. The classic threshold is approximately 26 gray. We should aim lower, maybe in the 20 to 22 gray range if possible, but 26 gray is the board-safe maximum.
And the contralateral submandibular gland.
We aim for a mean dose less than 39 gray.
Let's just briefly review the function of those two glands, because sparing both is really necessary for patient comfort.
Okay. The parotid gland is responsible for 65% of stimulated saliva. That's the flow you get when you're chewing or eating. The submandibular gland, located in level 1B, provides 65% of unstimulated saliva, your baseline moisture throughout the day.
So sparing the parotid helps with eating. Sparing the submandibular helps with speaking and sleeping without waking up dry.
Exactly.
Next, dysphagia prevention, which has gained enormous clinical significance as our patients live longer.
The defining trial here is the DARS trial, published by Nutting and colleagues in Lancet Oncology in 2023. This was a prospective trial specifically designed to test whether dose-limiting the pharyngeal constrictor muscles actually improved swallowing outcomes.
And what were the key constraints mandated by the DARS protocol?
They set a mandatory mean dose constraint for the superior and middle constrictors. specifically the parts outside the high-dose PTV of less than 50 grays.
And did it work?
It absolutely did. The DIRS trial showed a statistically and clinically significant improvement in patient-reported swallowing quality of life scores at 1 year compared to the standard planning arm.
So that constraint, mean dose less than 50 gray to the superior and middle constrictors, has now become a foundational quality metric in OPC planning.
And we must reiterate that anatomy pearl. By judiciously selecting only the lateral retropharyngeals, we are directly enabling that superior constrictor sparing.
Right. You're reducing the volume that receives a high dose and making that 50 gray constraint feasible.
Exactly.
We also need limits for the larynx to prevent chronic aspiration.
The standard constraint there is a mean dose less than 40 gray to the glottis and supraglottis region. This helps minimize edema and potential long-term aspiration.
Okay, let's move to mandible osteoradial or ORN. We need to move beyond just saying Dmax less than 70 gray. We need a DVH-informed approach.
Yes, examiners look for sophistication here. ORN is a complex, volume-dependent toxicity related to high-dose compromising bone perfusion and cellular turnover. The classic high-dose volume metrics, derived largely from Fox Chase data, are essential.
What are those metrics?
V44 less than 42% and V58 less than 25%. These constraints try to limit the volume of the mandible receiving substantial dose, which is 44 gray, and the volume receiving a near ablative dose, which is 58 gray.
But what if our patient's 4 centimeter level 2 node is right up against the mandible? High dose is going to be unavoidable.
In that situation, you must state that the trade-off is unavoidable. You document the increased ORN risk, and you make every effort to minimize dose heterogeneity, meaning keep the hot spots inside the target volume and away from the bone surface.
So a good planner accepts the trade-off while showing they tried to adhere to the DVH constraints as closely as possible.
Precisely.
Finally, the critical structures with absolute limits. These are non-negotiable Tier 1 priorities.
First, the spinal cord. The maximum dose must be less than 45 gray to prevent the risk of transverse myelopathy.
Second, the brainstem.
The maximum dose must be less than 54 gray, which guards against necrosis or severe cranial nerve deficits.
And the cochlea, which is a major factor when concurrent cisplatin is involved.
Yes, the cochlea mean dose should be less than or equal to 35 gray. Given that cisplatin is a potent ototoxic agent, the goal is often even lower. You're aiming for below 20 grays on the ipsilateral side to minimize the risk of profound hearing loss, especially for older patients.
We have our limits defined. Let's move to the nuts and bolts of the dose, fractionation, and evaluation. We use the simultaneous integrated boost, or SIB, technique.
The standard scheme is the 7-week 35 fraction SIB.
Let's verbalize the 3 dose tiers for our T2N1 case.
The GTV and CTV high receive 70 gray in 35 fractions, so that's 2.0 gray per fraction. The intermediate CTV receives 63 gray in 35 fractions, or 1.8 gray per fraction. And the elective, low-risk CTV receives 56 gray in 35 fractions, or 1.6 gray per fraction.
We need to defend that elective dose. Why is 56 gray sufficient for microscopic control?
Well, we have to ensure the dose meets the minimum requirement for microscopic disease control, which is an equivalent dose in 2 gray fractions, an EQD2 of at least 46 gray.
And 56 gray delivered in 1.6 gray fraction.
Calculates to an EQD2 of approximately 53 gray, which substantially exceeds that 46 gray minimum. Therefore, 56 gray is biologically sufficient to clear any potential microscopic involvement in the uninvolved neck.
Briefly, let's address accelerated RT.
RTOG 1016 use an accelerated regimen of 70 gray in 35 fractions over 6 weeks, so 6 fractions per week. While it shortens overall treatment time, which is biologically favorable, the increased potential for acute toxicity, especially with cisplatin, means that 5 fractions per week remains the most common and standard practice.
You mentioned the intermediate dose controversy, the 70/63/56 versus the 70/56 scheme.
Either 2 tiers or 3 tiers are acceptable, but the resident needs to know their institutional approach. The rationale for that intermediate 63 gray tier is to treat areas like the high-risk lateral RP nodes or the ipsilateral parapharyngeal space with a dose that's a bit higher than purely elective, but without committing the full 2 grays per fraction.
Now, plan coverage goals during the final evaluation. What are the metrics we demand the plan meets?
We use the D95 metric for the PTV, requiring that the dose received by 95% of the PTV be greater than or equal to 95% of the prescription dose.
But we always prioritize the CTV coverage.
Absolutely. The ultimate metric is the CTVD99, the dose received by 99% of the clinical target volume, which must be greater than or equal to 100% of the prescription. We prioritize covering 100% of the CTV over achieving 100% coverage.
Okay, let's define homogeneity limits. We need to avoid uncontrolled hotspots.
The plan has to ensure good dose homogeneity. Generally, no more than 10 to 20% of the PTV should receive greater than 110% of the prescription dose. And crucially, any necessary hotspots must be confined entirely within the GTV or CTV volumes, far away from sensitive structures.
That brings us to the conflict hierarchy, which is the most tested area of judgment in an oral exam. Planning is all about managing those inevitable conflicts between coverage and sparing.
Right. This hierarchy defines our clinical decision-making when the constraints can't all be met. Priority 1, never compromise. This includes the absolute dose limits for the spinal cord and the brainstem. These are red line violations.
Priority 2, strongly prioritize CTV coverage. Tumor control is the primary therapeutic intent.
So we accept a compromised OAR dose if CTV coverage is at risk.
And priority 3, balance carefully. This includes the parotid, the pharyngeal constrictors, and the mandible. These are our quality of life constraints. We strive for the established goals, but they are subservient to priority 2.
Exactly.
Let's walk through a critical trade-off simulation. Our plan currently achieves 100% CTV70 coverage, but the contralateral parotid mean dose is 29 gray. If the dosimetrist tries to drop the parotid mean to the goal of 26 gray, the CTV70D99 drops to 98%. What's the defensible action?
The defensible action is to accept the higher parotid dose of 29 gray. We would document that ensuring CTVD99 coverage, which is priority 2, superseded the goal constraint for the parotid, which is priority 3.
So we accept a manageable long-term toxicity to preserve the chance of cure.
Yes. That demonstration of prioritizing tumor control over a quality of life metric is what the examiner is looking for.
Conversely, what if the plan meets 100% CTV coverage, but the mandible V58 is 35%, exceeding the recommended 25%? How do we approach that?
Since CTV coverage is maintained, we have to work to optimize that mandible constraint. We'd look at the dose gradient near the bone. If we can shift the high dose contour, maybe by tightening the PTV margin at that interface while keeping the CTV coverage.
And thus reducing the V58 percentage to, say, 28%.
That is the right optimization. We don't stop optimizing priority 3 OARs until priority 2 is threatened.
That detail elevates the discussion from simple memorization to complex clinical judgment. Now let's solidify this learning with the most common planning pitfalls, the mistakes that examiners look for.
Okay, pitfall number 1. Missing retropharyngeal nodes when anatomy requires it. If the case involves a T3 tumor extending along the posterior pharyngeal wall, and you fail to include the ipsilateral RP nodes, what have you done?
You've created a geographic miss in a known first echelon drainage area. That's an immediate red flag that the planner doesn't understand head and neck lymphatic drainage patterns.
Pitfall number 2. Routinely including level 1B for a tonsil cancer without oral cavity extension. This is that common mistake of thinking more is better.
And the consequence is unnecessary harm. Level 1B covers the submandibular gland. By including it electively for a pure tonsil primary, you're just increasing the likelihood of chronic xerostomia without any gain in tumor control.
It's an indefensible overtreatment.
Absolutely. What's pitfall number 3?
Treating the bilateral neck when ipsilateral would be appropriate. This happens when the ARS criteria are ignored or forgotten.
This demonstrates a failure to balance toxicity. If the patient has a well-lateralized T1N1 primary that meets all 4 ARS criteria, choosing bilateral coverage needlessly doubles the dose to the contralateral parotid gland,
resulting in a preventable, permanent quality of life detriment. Understanding these pitfalls is often more valuable than reciting the constraints themselves.
Totally agree. Okay, time for the board review section, where we apply these rules in a rapid-fire quiz format.
All right, question 1. A 58-year-old woman has P16 positive squamous cell carcinoma of the right tonsil T1N1. It's a single 2.5 centimeter level 2 node. The tumor is well lateralized, more than 1 centimeter from midline. no soft palate or base of tongue extension, no ENE on imaging. Which approach to neck coverage is most appropriate? A. Ipsilateral levels 2 through 4. B. Bilateral levels 2 through 4. C. Ipsilateral levels 1B through 4 plus bilateral retropharyngeal nodes. Or D. Bilateral levels 1B through 5 plus bilateral retropharyngeal nodes.
The best answer is A, ipsilateral levels 2 through 4.
And the rationale.
This patient is the ideal candidate for de-intensified ipsilateral treatment. She meets all ARS criteria. T1, well-lateralized single node and no high-risk extension. Bilateral treatment would be overtreatment, and level 1B inclusion is completely unwarranted.
Perfect. Question 2. During plan review for an oropharyngeal cancer, you note the following. CTVD 99 is 100%, PTVD 95 is 94%, contralateral parotid mean is 24 gray, superior constrictor mean is 48 gray, and mandible V58 is 35%. What is the most appropriate assessment? A. Unacceptable PTVD 95 must be greater than or equal to 100%. B. Acceptable CTV coverage is maintained and OAR constraints are reasonable. C. Unacceptable mandible V58 exceeds the 25% threshold. Or D. Replan to improve PTV coverage even if it means exceeding parotid constraints.
The best answer here is B. Acceptable CTV coverage is maintained and OAR constraints are reasonable.
Explain your thinking.
CTV coverage is the non-negotiable priority, and it's at 100%. The PTVD 95, falling slightly short at 94%, is acceptable, and in this context, it's justified because it allowed for excellent sparing of the parotid and the constrictors. The mandible constraint is violated, but the excellent CTV and other OAR sparing make this an acceptable trade-off.
Excellent. Last one, question 3. For P16 positive tonsil cancer, which of the following is the most appropriate indication for including level 1B in the elective CTVA? Bulky, so greater than 3 centimeters, ipsilateral level 2 adenopathy. B. Extension of tumor into the oral cavity. C. Soft palate involvement. Or D. Ipsilateral retropharyngeal node involvement.
The best answer has to be B, extension of tumor into the oral cavity.
And the rationale is key.
Right. Level 1B drains the oral cavity. Even bulky nodal disease elsewhere or extension to the soft palate or RP involvement does not automatically justify level 1B coverage. Only documented oral cavity extension triggers its inclusion.
Fantastic. Let's distill all this technical detail into our high-yield clinical pearls, the mnemonics and phrases that will stick with you.
Okay, pearl number 1.
5 plus 5. GTV to CTV high is 5 millimeters. GTV to CTV intermediate is 10 millimeters. And remember the Dahan-Ka data. These standardized, tight margins work if your imaging is excellent, but you must crop anatomically.
Pearl number 2. 1B is for oral cavity. Level 1B is not routine elective coverage for tonsil cancer. If you include it without oral cavity extension, you are inducing unnecessary xerostomia.
Pearl number 3. 1 centimeter from midline, 1 centimeter of palate. This summarizes the ARS criteria for ipsilateral treatment. Well-lateralized tonsil, less than or equal to 1 centimeter of mucosal soft palate or BOT extension, minimal nodal burden, and no posterior pharyngeal wall involvement. If in doubt, err toward bilateral.
Pearl number 4. Parotid around 26, constrictors under 50. These are your two primary quality of life constraints. Parotid mean around 26 gray, and superior and middle constrictor mean less than 50 grays outside the target, which was proven by the DARS trial to improve swallowing.
Pearl number 5. Lateral RP, spare the constrictors. Focus your retropharyngeal coverage only on the lateral RP nodes. This is the key anatomical technique that allows you to spare the superior pharyngeal constrictors and minimize that dysphagia.
And our final, provocative thought to take with you. Meticulous planning isn't a luxury. It is as critical to survival as the systemic therapy itself. The TROG 0202 data prove that planning errors kill patients. Your first and most important job is to know your target expansion principles and rigorously apply evidence-based nodal coverage algorithms.
Absolutely. Making board-defensible decisions that prioritize tumor control while fighting for quality of life.
That's the whole game. This was an extensive and critical deep dive into the practical application of OPC radiation planning. Let's quickly recap the 6 key learning points we hammered home today.
First, the required simulation setup, supine, mask, neck extended, shoulders down, and the non-negotiable necessity of MRI fusion for mucosal staging.
Second, that systematic 5+5 rule for target volume definition, emphasizing tight, anatomically confined margins backed by the Dahan-Ka data.
Third, the bilateral versus ipsilateral decision framework using the ARS criteria, stressing the danger of the 1 centimeter ambiguity and the need to default to safety when you're uncertain.
Fourth, the specific modal coverage rules, detailing the exclusion of level 1B for routine tonsil coverage and that technique for lateral-only retropharyngeal coverage.
Fifth, the hierarchy of OAR constraints, prioritizing spinal cord and brainstem, followed by CTV coverage, and then optimizing for salivary function and swallowing based on the PARS, PORT, and DRS data.
And sixth, plan priorities. CTVD99 coverage is non-negotiable, and we accept minor PTV compromises at the OAR interface only when it's necessary for critical quality of life sparing.
That sums it up perfectly.
Complete practice oral boards at radongsmartlearn.com and subscribe to Radong Smart Review for our next episode. Thanks for tuning in.